Welcome to Robert Wood Johnson University Hospital, Somerset's Health Talk. I'm Dr. Douglas Ashinsky of RWJBarnabas Health Medical Group's Warren Internal Medicine. In accordance with social distancing due to COVID-19 pandemic, I am hosting the show from the studio, and our guests will be joining us remotely via video conferencing. Individuals with heart disease at a higher risk for severe illness from COVID-19. On today's show, we will discuss precautions that people with heart conditions should take during this time, as well as the importance of not delaying medical care. We will also get overview of heart disease prevention and treatment. Our special guest is Dr. Oxana Ovakiyman, who is board certified in internal medicine and cardiovascular disease. She's a member of RWJBarnabas Health Medical Group's Barone, Catania Cardiovascular Group and is on staff at Robert Wood Johnson University Hospital, Somerset. Welcome to the show. Dr. Ovakiyman, I'm sorry, I hope I don't ruin your name too frequently, but can you tell us a little bit about your background itself? Tell us medical school and then how you got into cardiology and your interests in cardiology.
Absolutely. Good morning, Dr. Ashinsky. Thank you for having me on the show. As Dr. Ashinsky said, my name is Dr. Oxana Ovakiyman. For most patients, I go by Dr. Oxana to make it easy. I'm an interventional cardiologist locally with RWJBarnabas Medical Group. I graduated from medical school in Moscow, Russia, completed a residency in Russia, another residency at Overlook Medical Center here in New Jersey, then cardiology fellowship at Morristown Medical Center, and interventional fellowship at Brown University in Rhode Island. After all of that, I decided to come back to New Jersey, to my American home, and established within the practice with Dr. Raymond Catania and Dr. Paul Barone right here in our neighborhood, Watchung, New Jersey. I decided to become a cardiologist because to me it was the most fascinating organ, simplest thing, a muscle, 4 chambers, few valves, but one thing goes wrong and everything goes wrong. So I decided to proceed with trying to find everything I can about that organ. And the more I learned, the more I realized that we don't know too much about it. So, every day is a learning in this field.
That's interesting. And thank you for telling us a little bit about yourself. Now, during this COVID time period, as you know, heart disease still remains very active out there. And unfortunately, patients are a little taken aback about not going to the physician or talking about heart disease. However, heart disease doesn't end due to a pandemic. So can you tell us risk factors about heart disease and why even during a pandemic, people should get in touch with either their primary care doctor or if they have a cardiologist such as yourself, why they need to keep up with everything?
Absolutely. I agree with you 100%. Heart disease obviously didn't end with COVID coming in. We did, however, notice a decreased amount of the acute events, such as acute heart attacks. The reason for that is not really known. There's some concern that some people may be afraid to come to hospitals and having events at home and possibly even dying at home, not really knowing what's going on with them. That is why it's so important to pay attention to your symptoms. If you have any symptoms, such as any significant chest pain, new onset shortness of breath, pressure in the chest, if you feel suddenly very sweaty and associated with discomfort in your chest, those symptoms require immediate medical attention. You should not delay your care. The hospitals are safe. They make sure that they segregate patients with COVID and non-COVID. At Somerset Medical Center, for example, they everybody obviously gets temperature checks. Everybody gets the masks. The staff approaches with you with full coverage to make sure that if they have something, they cannot pass it on to you. Everybody gets tested for COVID, whoever comes into the hospital, so we know exactly COVID status of every single patient in the hospital. So it is extremely safe to come in, so you should not delay your care for any kind of a life-threatening cardiovascular condition just because of fear of getting COVID. The chances of you getting COVID in a hospital are much less than in the community at this time because of all the precautions the hospital takes. There are several cardiovascular conditions which make your chances of having adverse outcomes with COVID worse. We know that men tend to have worse outcomes than women, men with hypertension especially, but the more serious underlying conditions such as diminished heart function, such as cardiomyopathy or heart failure, as well as significant coronary artery disease are risk factors for more adverse outcomes with COVID. They do not make you more or less likely to actually have the infection. They just make it a more severe infection requiring maybe a hospitalization or possibly even respiratory support.
Okay, so
So
let's
people who do have those conditions have to take extreme precautions and try to avoid any kind of contact outside of their home.
let's stop. Let's step back one more step. We've got someone who is 40 years old. What are the risk factors for that person for heart disease itself? Not COVID itself, but let's first start with heart disease itself.
So we have factors which we cannot address, such as our genetics. If we were born to somebody who had heart disease, mother and father, obviously those are what we call non-modifiable risk factors. It's just what it is. But there are a lot of modifiable risk factors, such as smoking being probably number one, high blood pressure, high cholesterol, and other adverse, kind of a habit such as excessive drinking and so forth. But out of all of them, the blood pressure, cholesterol, and smoking are probably the most easily modifiable risk factors. Additional risk factor, which is a little bit hard to put in exactly, is obesity. Obesity increases risk of all those risk factors. So, ultimately it increases risk of heart disease, such as predominantly when we talk about heart disease, it's a big umbrella term, but most often we refer to coronary artery disease, which is cholesterol buildup in the arteries of the heart, resulting in blockages.
And of course, diabetes itself also.
Diabetes is a main major risk factor. Again, we rarely have people with just diabetes. Usually people who have diabetes also have high blood pressure and cholesterol, and people who have high cholesterol and diabetes have high blood pressure. This trifecta are very commonly seen in one patient.
And in fact, when we see a patient who's 40 years or above, whether it's a male or female, and they have diabetes, normally we consider that a double cardiac risk factor. So basically,
Yes.
You have diabetes, you have to figure that you probably have some underlying coronary artery disease.
That's correct. Actually, some experts actually consider diabetes as a de facto type of it's like a equivalent of coronary artery disease, especially if you have had it for quite a while.
So in other words, what we need to do when we're seeing a primary care or a physician, or if we're seeing the cardiologist, is we need to modify those risk factors. So if we have diabetes,
Absolutely.
we want to control the diabetes as well as humanly possible, whether it's through oral medications or injectable medications, as well as diet and exercise. If it's cigarette smoking, we'd love to have the person stop smoking. If the person is overweight, we'd love them to follow some type of a good diet, see a dietitian, get onto a nicer exercise program. If the person is overweight or obese, we'd like them to follow a good diet, exercise program. And again, we're looking for a half a pound of weight loss a week. If we can get a half a pound of weight loss a week, by the end of a year, we're talking about 26 pounds, which really makes a tremendous difference. Even if the person is large, it really does make a big difference. And if we go back to the old studies about losing 1 pound and it reduces the cholesterol values, it also should reduce the cholesterol values also.
Absolutely, that's correct. Weight loss will result in lower cholesterol, lower blood pressure, and lower sugars directly.
And then, of course, as you said, then we have things like gout, which we think is a cardiac risk factor, not completely sure about. That may or may not be easily modifiable, maybe just, again, diet type of program, a low purine diet. But family history, another big thing. Unfortunately, if there is a family history of someone having early onset of atherosclerotic heart disease before the age of 50, that increases your risk. So as a primary care doctor, if I've got someone who's 40 years old who has a family history, it's very important for me to get them over to a cardiologist such as you or Dr. Barone or Dr. Catania, just to get some risk factors to decide what the risk factors are and see how we can modify them.
Yes, having obviously family history of premature disease, especially if you had a mom and dad who had heart disease before age 50, 45, that definitely increases your risk. Sometimes those risks are related to specific genes coding, such as like really high cholesterol levels, but sometimes it's just multiple genes which we cannot particularly find. But having a family history of heart disease in a first-degree family member, including such as your brother or sister if they had premature disease, people do require a little bit more in-depth evaluation. The same thing pertains to them, controlling risk factors such as high cholesterol, high blood pressure, if they have diabetes, controlling their weight. but they may also include additional tests to look to see if such person who has a family member who had disease at a younger age is prone to having it at a younger age as well. That may include checking such thing as high sensitivity CRP. It's a blood test to look for inflammation in our system, which is associated with more atherosclerosis. As you mentioned, gout can increase risk of coronary artery disease, as well as other inflammatory conditions such as rheumatoid arthritis, lupus, and any other autoimmune conditions do increase inflammatory markers in our system and do accelerate cholesterol plaque buildup. We also have a test called coronary calcium CT testing, which is a low radiation CAT scan of the chest, looking to see if there's any calcified plaque in the arteries of the heart. Tends to be a very helpful test in individuals between ages 40 to 60 to try to see and compare them with their age and gender matched people to see if they have more or less plaque buildup by that point. That helps sometimes to find the best treatment goals for patients, because not everybody needs the same number of cholesterol goals. People who have plaque, they have much lower levels of cholesterol we have to achieve.
So once again, I've got a 40-year-old and every year afterwards coming in for an annual wellness exam. What we need to get out there to the public is if there are risk factors, 2 or more risk factors, it's important that they are sent over to their cardiologist or get in touch with a cardiologist such as your office and get themselves into seeing you periodically. And what's nice about an office such as yours is you do both non-invasive as well as invasive cardiology. So you have the full complement, the full suite of cardiology in your office, or if necessary, over at the hospital.
Yes, absolutely. We can provide pretty much all cardiac testing in a hospital except for invasive tests. We do all cardiac testing, including echocardiogram, vascular studies within our office, heart monitors of all variety of lengths. Everything can be done in the office or within very short vicinity of full service cardiology, consultative, and imaging.
So it's wonderful to have an office such as yours as part of the Robert Wood Johnson Barnabas Healthcare Network, and the fact that since you are convenient and able to do things both at your office and at the local hospital, that our patients do not have to travel far to go to get the best possible cardiac services available.
Absolutely.
Now, being a woman yourself, I've heard that you have a special you're looking at risk factors and female risk factors for cardiac disease. Do you have something about that?
Yeah, so women as patients have a little bit of different kind of a sense, because even though we've always known in the past that women can have more atypical symptoms presenting with heart attacks, it actually, latest studies show that may not be true. A large study from Journal of American Heart demonstrated that women are actually more likely to have typical symptoms of a heart attack than men originally presenting, which was quite surprising to me because that was not the teaching I've had for years and years and years. And typical symptoms of heart attack usually involve pressure or burning in the middle of your chest or to the left of your chest. Sometimes it could travel to your jaw or to your left arm. It may or may not be associated with difficulty breathing, sweating, and a dizziness or lightheadedness. Those are typical symptoms coming together. Atypical symptoms are a stomach discomfort. You may just become suddenly sweaty, suddenly become really tired or fatigued. Those are actually present in approximately 1 in 4 patients, and more in men than women. Again, surprisingly, in a study shown that actually women have more typical symptoms. But what women have in comparison to men more is we have more disease of the arteries of the heart, not of the main arteries, the ones which we tend to treat with stents or bypass surgeries, but of the microscopic arteries. Imagine the arteries of the heart as a tree. You have a main trunk and it branches out into bigger branches and smaller branches and tiny, tiny branches at the tip. So most men have disease of those bigger trunks, the main trunk or the bigger branches. Those have relatively established treatments, which involves usually stents, bypass surgery, and obviously medication and lifestyle modification. That is absolutely goes with everyone. Women, though, tend to have disease of those tiny, tiny little branches. Those cannot be seen in any imaging test. They can only be assumed to be there by physiologic testing or specific other testing. But the idea is that those only can be treated with medications and sometimes are not easy to diagnose. And if not diagnosed and treated, could have adverse outcomes, including myocardial infarction, heart attack, which can have lifelong consequences. So a lot of times when women present to the hospital and they meet criteria for the heart attack, and when we do an angiogram or we look at the arteries and we don't find the main blockages, an idea right away in the doctor's mind would be usually there's nothing going on. It's not a problem. It was just a false alarm. But that's not the case. A lot of times it is the damage of the muscle of the heart related to those microscopic arteries. And if poo-pooed and not really taken care of, can result in a lifelong disability from cardiac standpoint. So my goal in life is to make sure that these women are not poo-pooed, that they're taken care of, that we treat them appropriately and minimize their risk of any future events.
So again, looking at modification of their risk factors to prevent the catastrophe later on in life.
Correct. Absolutely.
And yes, it is interesting because when we were all in medical school and training, it used to be that they used to tell us all that women don't have the normal cardiac symptoms when they're having the heart attack. Look for them to have more GI effects than it is for the shortness of breath, et cetera. So if, again, a patient who has multiple risk factors comes to my office with the either a shortness of breath, some chest pain, discomfort in there, possibly in the left arm, and I send them to Robert Wood Johnson Somerset Hospital emergency room, and I contact your office as the cardiologist to be seen. What happens when they get there, and can you run it through that in case it's severe that they have to go to the cardiac catheterization lab, because a lot of people are very afraid when they go to the emergency room that they may have to do that. And they should know that, especially nowadays, since, again, we do temperature checks, we ask them the questions, they get a COVID test when they come in, so we know what it is. We do segregate, and at this point at the hospital, there's basically minimum number of patients who actually have COVID at the hospital. What exactly goes on so patients are put at ease and understand that you're doing everything possible to help save them and get them back to their normal life?
Absolutely. So let's say, as you described, you have a patient, if a patient happened to be in your office and you were able to do an EKG at a time, a simple test to look at the electrical activity of the heart, sometimes that may be able to diagnose a major heart attack. Let's say the patient just called you and symptoms sounded very alarming, so you direct the patient immediately to emergency room, either by ambulance or somebody drove them in, hopefully by ambulance preferably. Patient comes to the ER. Any cardiovascular symptoms, such as you described, chest pain, chest pressure, sudden shortness of breath, require immediate attention by the emergency room physician. So patient will be evaluated right away. The EKG will be done within the first 5 minutes. It will be evaluated right away. EKG will be looked at. If EKG has signs of what we'll call major myocardial infarction, called ST elevation myocardial infarction, a specific type where we believe that the occlusion of the artery happened at the main trunk. Remember the tree again, the main trunk. Then this requires immediate intervention. So at that point, emergency doctor will give patient medication, usually some blood thinners, medicines to relax the heart muscle and relieve the pain, which may include nitroglycerin or morphine, depending on the blood pressure and other parameters. The treatment will be started immediately. Then I will, another cardiologist who's on call, be contacted immediately to confirm the EKG findings. And if it is confirmed that we believe there's a main artery blockage situation, a cardiac cath lab will be activated, meaning that all the team members who come in take care of you immediately. The procedure of cardiac catheterization, if that's what you need, is a low-risk procedure. It's done through a puncture. There's no cutting involved. It is done under what we call moderate sedation, where we give you medicines to relax you, because it is not a painful procedure. All you're going to feel is initial puncture with good numbing medicine, either in a wrist area or in a leg area where we enter the artery. There's really no pain afterwards involved. And usually people who are having a heart attack actually having a pain. And once we can actually get in the artery, find the blockage and put a little wire through it and then open it up and put a stent to expand the area where the blockage was, the pain in your chest will go away and you feel immediately better. It's like an immediate relief, like a switch went off and you feel much, much better. And that results in significant reduction of risk of dying from the heart attack and having further damage to the muscle in the area. The procedure lasts approximately an hour, give or take. Again, relatively safe, risks are very small. In our procedure world, we usually quote complication rate in less than 1%. In a lot of times it can be even less than 0.5%. So it is a very small risk procedure.
Okay, so After the person's finished with the stent or an angioplasty, can you just tell what the two different things are? Some people don't understand there's actually a little difference between an angioplasty and a stent.
Yeah.
What happens afterwards?
So angioplasty is more of a general term, meaning any kind of intervention on the artery of the heart. In the past, we used to refer to that mostly when we just did a balloon angioplasty, meaning that we just put a balloon, expanded it, and opened up the area. We haven't really, the stents are a relatively new invention. We had them for approximately 20 years or so. So prior to that, the only available technology was the angioplasty, where they would do the balloon. The success rate of that wasn't as high because you really need that stent to tack up the area of where the plaque, opened up and caused a heart attack. The stent is literally a metal mesh which is squeezed on a balloon, and we'll position it right where the blockage is, and we expand it and creates a metal mesh and seals the area completely and keeps the artery wide open. That is the stent procedure. It is an angioplasty, but it does involve stenting. So it's an addition to angioplasty, you get a stent. Stent stays in you, it cannot come out. Your body grows into it and kind of creates inside of the artery as your own artery. And that process takes approximately 6 to 9 months. You'll be placed on medications to prevent that stent from clotting, because initially it's a metal stent. It is a foreign body. So your body, obviously within the artery, has blood cells, and it doesn't seem to like that much of having a metal sticking out in there. So we give you an extra blood thinners. You're obviously going to be on aspirin. An extra blood thinner will be something like Plavix, Brilinta, or Effient. We have different drugs, and your doctor may choose it for a variety of reasons. You'll be on that drug for approximately 1 year after a heart attack, and at 1 year point, that can come off, and you'll be on aspirin lifelong afterwards. We will start you on medications if you're already not on medications to make sure that your cholesterols are well controlled and will prevent any more plaque from forming, because you have to understand that a heart attack is a process which happened at the time of symptoms, but what led to heart attack is a process which takes decades of cholesterol plaque buildup. So if we do not stop the process by starting on medication, then we're looking for another heart attack at some point in the future. The stents and bypass surgeries are treating the problem which you already have developed. They don't treat the underlying, they don't cure the problem. The only way to control the problem is making sure that we actually stop the process of cholesterol buildup by controlling your blood pressure if it's not already controlled, by making sure that your cholesterols are much lower than they're supposed to be in a healthy otherwise person, making sure that your diabetes is well controlled, and get a hold of your weight and make sure that we can do all we can to control that.
And what's important is that people need to understand this is a lifelong process, because many people, 6 months later, they get their cholesterol reading, and since they've had a stent, we're looking for that LDL cholesterol of less than 70. They've achieved it, so suddenly they say, I've done it, now I can stop everything. They can't stop it. What they need to understand is we need to keep the process in minimum. There were many studies years ago where they showed that you put people on statin medications and you reduce them from building up the clots. And what we're trying to do is that the angioplasty and the stent stop the acute events, but what we need to do is stop the prolonged reestablishment of atherosclerotic heart disease and make sure that the process of rebuilding up plaques doesn't continue.
Absolutely. You're absolutely correct on that. The process of actually building up plaque takes decades. Most people start some cholesterol plaque buildup starting in their teens, we call it fatty streaks. We develop those plaques. And in some people, it's much more exciting than others. Majority of people in their 70s or 80s will have some plaque. Some have a lot of plaque. Some have minor amount of plaque. But we're all ultimately going to develop some plaque. So making sure that that doesn't happen too fast and doesn't result in heart attacks requires strict control of blood pressure, cholesterol, diabetes. With cholesterols, as you said, the medicines only work when you take them. Unfortunately, we do not have an injection or something we do once and done. Unfortunately, if you stop taking medication, that beautiful effect you achieve with getting your LDL cholesterol down to excellent levels will undo itself within 1 month.
So what do you want to tell the general public? How often should they check their blood pressure? How often should they check their cholesterol?
So generally we recommend for people over 35 to 40 to have at least blood pressure check once a year if they don't have any additional risk factors such as strong family history or prior history of cardiac problems. With cholesterol checks, if their cholesterol at the age of 35 or 40 was normal and there was no change in their overall status, no significant weight gain, and usually cholesterol can be checked every 3 years or so. If you do have elevated cholesterol or borderline cholesterol, that probably should be checked at least once a year. If you're on medication medication, the goal of cholesterol depends on a variety of factors, such as if you have underlying heart disease, severity of that heart disease. Generally, the LDL, what we call bad cholesterol, is what we target our therapists to. In a healthy population, we like that number to be less than 130. In population of anybody who has some cholesterol plaque, it has to be at least less than 100, ideally less than 70, and most certainly less than 70 in somebody who had a heart attack or a stroke. European guidelines actually recommend for high-risk patients to go as low as less than 55, and that tends to be my target for young patients who had a heart attack. Because if you're a 45-year-old and you had a heart attack, that makes you a very high-risk person, because I would like you to get to 85, 90. So in order for you to get that there, we have to make sure that we slow that process of further cholesterol buildup to a turtle level, as slow as it possibly can, or hopefully hold it all together. And that requires, good dose of statin medications, sometimes other medications, and really, really motivated person to address their lifestyle.
So again, the core that people need to understand is, one, you need to really look at yourself. You need to look at your blood pressure periodically, and if you're elevated on the blood pressure, please control the blood pressure. Two is, if there's a family history, that puts you at a significant risk for cardiac disease yourself. Therefore, it's much more important that you follow up periodically with either your primary care, or if at all possible, please ask your primary care doctor to send you to the cardiologist where they can do further testing, which is indicated based on what their risk factors are. Three is that if you have diabetes, please get the diabetes under as best control as possible. Four is, we're looking overall for your overall health. What happens if what you're doing between ages 35 and 50 affects the rest of your life, because it's what your body's laying down, and we'd like you to go to age 90, have the ability at age 90 to still do everything possible and not be on a whole slew of medications. So modifying risk factors really makes a difference.
It most certainly does. As simple intervention as controlling your diet and trying to avoid as much as possible animal products, including animal-based products such as eggs, milk, dairy, will reduce your risk of heart attacks in the future. Generally, from a cardiovascular standpoint, the best diet we recommend right now is a low-fat, whole foods, plant-based diet, which is essentially a vegan diet. It is a difficult diet to maintain lifelong, but the closer you can get to that, you can reduce your risk of events and slow down the atherosclerosis buildup process naturally by as much as fourfold. So out of all the interventions we can do, if you really, 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 get motivated and try to substitute most of the animal products with plant-based products, you can reduce your risk substantially. And that a lot of times allows us to lower your medications, even take you off some medications, which some people are very happy about, because most of my patients hate pills, okay? And, I hate giving pills too if I don't have to. So if we can team up, if you team up with your primary care doctor, your cardiologist, and address all parts of it, because there's no magic pill, okay? We do need medications, some patients, absolutely. But if you do not control the lifestyle, medications is just a Band-Aid and it's going to keep falling off. So we need to address all things together, the medications, we have to address your diet, we have to make sure you do at least 30 minutes of activity every day. If you combine all those things, then we can substantially reduce your risk of any future events.
Thank you, Dr. Oxana, for being here with us, and thank you for giving us all that knowledge on cardiac disease, atherosclerotic heart disease, angioplasty, et cetera. And I hope that in the future we'll learn more and more, and you'll be able to come back here and explain even more to our audience.
Absolutely. Thank you for having me.
This concludes today's episode of Robert Wood Johnson University Hospital Somerset's Health Talk. Please remember, the opinions expressed here by our medical experts are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset, please visit our website at www.rwjbh.org/Somerset.